بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. سبحانك ربنا هديتنا لهذا وما كنا لنهتدي لولا أن هدانا الله. It is my great pleasure and honor to invite Professor Kemal Tolga, and he's so elegant and kind one. He acting high and mighty, behaved nobly. My appreciation and grateful for your kind support, Professor Kemal. Thank you, Prof. Thank you for your kind support of our e-learning program. Thank you, Professor Kemal.
Thank you very much.
Of course, I have no suitable words to appreciate my great pleasure and honor for Professor Yasser Tobl for his continuous kind support. Thank you, Professor Yasser. You are the elegant moderator today. We have a man-to-man game today between Professor Kemal as a presenter and Professor Yasser as a moderator. Of course, we will have an amazing presentation. Thank you for your post. God bless you.
Yes.
We have a new event to elaborate a new generation how to present, and we have today Mahmoud Abdel Qawi. He is assistant lecturer. He will present an anesthesia news in less than 7 minutes, inshallah ta'ala. شكرا جزيلا.
Can you start, Mahmoud?
I'll start presenting now. Assalamu alaikum.
Yes.
Bismillah ar-Rahman ar-Rahim. Hi everyone. Our topic now is regarding pulmonary hypertension. I choose the best wallpaper for this, representing this topic, representing the most important part of the topic. If you can imagine the heart, our right is the left ventricle, our left is the right ventricle. Here, with complications, the right ventricle obstructs the venous return, and thus blood flow to the organs is reduced. That is our main problem with pulmonary hypertension. I like the quizzes and the questions. This quiz goes like this: a 55-year-old patient with a history of untreated obstructive sleep apnea presents for a total knee replacement. A full cardiac evaluation completed prior to surgery revealed a mean pulmonary artery pressure of 32 millimeter mercury. Which of the following anesthetic agents should be avoided this patient? So the examiner is very wise and very precise in choosing his words. He didn't mention the planned technique of anesthesia. After thinking the answer to this question, this question is for the single best answer. So you may find that more than one answer is right, but the best answer is nitrous oxide. And don't mistake nitrous oxide with nitric oxide. And we'll go through this, but the bit of information which is important in this question is nitrous oxide. A quick note regarding this: many patients with neuraxial anesthesia are administered nitrous oxide as a sedative agent, but with this patient, it's contraindicated. Now we'll go through the pulmonary hypertension. I present this presentation mainly for those colleagues with some experience with pulmonary hypertension, but we'll go through I will illustrate regarding those for those who don't have some experience. But the most important parts are first, these are citations from very highly qualified, respectful sources. That is senior experience management is essential with patients with pulmonary hypertension, and consider referring any patient in the intermediate or higher risk categories to a specialized specialized pulmonary hypertension center for their surgery. Regarding this specialized pulmonary hypertension center, I'll not go too far, but this what is meant by specialized pulmonary hypertension center from the European Society of Cardiology guidelines, which is published on July 2022, just 2 months ago. These are some examples of pulmonary hypertension centers. These are what is important for us as anesthesiologists regarding pulmonary hypertension, which are the complications of pulmonary hypertension. This is the acute significant elevation in pulmonary artery pressure, which is pulmonary artery pressure, pulmonary hypertension, and the right ventricular failure. These are the main steps. Don't forget to start with hyperventilation to maintain arterial carbon dioxide at 25 to 28 and ensure oxygen supplementation to prevent hypoxic vasoconstriction. You can miss a nitric oxide, not nitrous oxide, which is a pulmonary vasodilator. And then we go through nitroglycerin, which is available to us, and other important medications which we hope to be available, like alprostadil and evoprostenol. Regarding right ventricular failure, it's not very mistaken for us. We can use vitamin, dopamine, epinephrine, and merinone, phosphodiesterase inhibitors. Regarding providing anesthesia for those patients, we need to take this information as main target balance of maintaining right ventricular output and avoiding
Yes, go on, Mahmoud.
Now, to continue, we need to maintain ventricular return and cardiac output. Okay. Now, regarding the conduct of anesthesia, it as routines. The most important parts have we have paused. Routine like to maintain oxygen supplementation, to provide warmth to the patient, monitoring, which is standard, and arterial monitoring is not that difficult, and it's very respectful, provides many information. You can provide esophageal echocardiography. Its insertion is not problematic, but its interpretation requires skill. Maintain normal volemia, not hypovolemia, not hypervolemia. You should monitor intravascular volume status. This regarding the medications. We had this for isoflurane in our choices in the question of the quiz. Isoflurane, they produce increase in pulmonary vascular return and marked ventricular depression. Propofol, thiabental, ketamine increases pulmonary vascular resistance. These are our main targets. So, in summary, when providing anesthesia for patients with pulmonary hypertension, you have to make sure what is the risk, and prepare before induction to keep with you ready norepinephrine and nitrates for managing any acute event. Regarding the cardiology related notes in summary, regarding the definition of pulmonary hypertension, it's mean pulmonary artery pressure more than 20, not 25 millimeter mercury at rest, and right heart catheterization is the gold standard for diagnosing and classifying pulmonary hypertension. Many patients are mistakenly diagnosed as pulmonary hypertension. You can suspect they have disease of pulmonary hypertension, but they can't diagnose. You can't make sure without right heart catheterization, and they are making effort to choose other investigations. like this algorithm, the last effort of the European Society of Cardiology and the last effort of American Heart, which is strangely surprisingly published on September 2022, 2 months after the European Society guidelines, right heart catheterization to do or not to do. They are trying to delay it as possible. This is this algorithm regarding the pathophysiology of right pulmonary hypertension. Over pulmonary hypertension have 5 groups. That is a classification, the formal classification, which is pulmonary arterial hypertension, pulmonary hypertension with left heart disease, pulmonary hypertension with lung disease, pulmonary hypertension associated with pulmonary artery obstructions, and pulmonary hypertension with unclear or multifactorial mechanisms. This is regarding the pathophysiology of pulmonary arterial hypertension. It starts with increase in the atrial pressure and increase in pulmonary arterial pressure. Then this reaction with the pulmonary artery regarding pulmonary circulation starts to be hypertrophied, and then ends with affection of the right heart, the right ventricle, and the tricuspid valve. This is a risk grading for patients with pulmonary hypertension by the European Society. And thank you for your listening. I hope you have taken benefit from this presentation.
Thank you.
Thank you, Mahmoud, for your presenting your fast news about pulmonary hypertension. Was a very important topics. Now, know that first of all, for this night, just thanks for the MAPIC platform under the dynamic head, Professor Safa Hilal. Usually I give her the name, the house power of the cell, like a mitochondria. And thanks for her and for the platform to inviting me as a moderator for this night, especially with a friend, Dr. Kemal Tolga, Prof Kemal Tolga. And our speaker today, who know Prof Kemal or not, is a star in the sky of anesthesia, airway management worldwide. Really, Mamnoon Oldum. This is an honor to be with us today, Dr. Prof Kemal. This is a Turkish language because it's my second language. Prof Kemal Arkatish Jim is my friend. Shukr Drez. Thanks for you to be with us today. And we hope Yakinda Tikrar Guru Shiris to be with us many times, to see you again in MAPIC platform. Return to Prof Kemal Tolga. He was certified from Istanbul University. It's a very big university. I get a training for more than 2 months there, so I know it is a very big university. It resembles Cairo University or more bigger than this. And I was lucky to get 2 months there training with Prof Serdar Erdin, one of pioneer in pain management. And also I am lucky also because Prof Kemal working with us now in Hamad Medical Corporation. He's a professor and was a professor and the head of department of anesthesia in health science, University International Medical School of Istanbul, Turkey, in Istanbul, Turkey. He's a board secretary and vice president of European Airway Management Society. He's a chair of European Society of Anesthesia Scientific Subcommittee of Respiratory and Airway Management. He's a chair of simulation and technical department of Sintorg Academic Corporation. Is president of Turkish Society of Medical Simulation. And also he's a reviewer in more than 9 or 10 reputable magazines like European Journal of Anesthesia, Turkish Journal of Anesthesia, and many other Journal of Anesthesia. And if I will speak in this session about the CV of Tolga, of Prof Tolga, I need about 40 minutes. There's a time of presentation. So now it's called, I was working a few days ago as a head of coordinator, head of OR. So I got trauma code, and I sent one of the most professional was asked to if they need an intubation, and he called me after 15 minutes, tell me that just come now. because I put a tube, but I don't see that the tube in the trachea, something wrong, and I feel the patient have an pneumothorax and surgical emphysema. I went there, I checked by fiber optic, I found the tube, he put the tube, and the tube coming from a tear in the anterior tracheal becomes subcutaneous. And the patient saved until we transfer him to OR and put an fiber optic again, and was a very bad trauma in the face, head, and neck. And the people there, surgery decide to make an exploration and just we put a tube again in OR because better facility. I remember at that time Kemal, Nabil, but I don't have a time to call him to ask him about what to do. But Alhamdulillah, the patient saved because I learned from him in this ultrasound workshop a lot. I learned from Kemal, I learned from Nabil, one of the good people in Airways here. So after that, I got a message. How can you classify this penetration, and how can you learn and what's called an traumatic airway management? Yeah. Anyone just have an open phone? Can you mute it, please? And I know what is the incidence, because this, I think this is the third time to happen in my call, and I get call over 15 days. So I must know also the etiology of upper airway bleeding, challenges posted for upper airway bleeding, and technique and the key points for upper airway management. So it is the objective of our talk today, and the stage is your Prof Kemal, and we need to learn from you today. Thank you, Dr. Kemal. You can share your presentation.
Thank you very much, Dr. Yasar Toble, for this kind words. Really appreciate. So I would like to also thank to Professor Sefa Halal for inviting me here. I'm trying to share it now.
Yeah, we see it, but we need to be on what's called a slide share. It's okay. Can you open? Yeah.
Okay, you see now?
But this is not open to be slide share. Can you, yes, down, click down again?
Can you see the slides now?
Yes, I see slides, but we need a slide share to be on all the screen, you know? So we can press down this slide share.
Yeah, I'm sharing now the screen.
You see all full screen slide, but we didn't say it's okay, you can go. But I think it's a video not working in this one. You need them to be on open slide share.
Can you see the full screen now?
No.
Okay. Sorry, I'll try again. Yes.
Yeah.
Tamam. Buradasın.
Bunu yaptım. Bunu yapalım.
Bunu yap bakalım. Şöyle.
How is it now? Can you see?
It's not full screen also. We need full screen. Can you press down this full screen? You press it down. This is an icon down to be full screen.
Just a moment. Stop the share. Again, share screen. Okay. You can use advanced Finet. Bir dakika. Şunu da şöyle çekelim. Bunu da şöyle aç. Şöyle yapalım hayatım. Nerede presenter? Adını açalım. Tamam. Şimdi şunu şöyle yap.
Yes, now it's okay.
Now
Just a
okay.
moment. I will.
Yeah, no,
I'm
okay.
so sorry I intervene you, but just try to help Tolga.
Thank you very much.
You're welcome.
But this is from definition. We need the first slide.
Okay. Okay, I will do this for you. Okay. Now, is it okay?
Yeah, it's okay. Yes, okay now.
Very nice meeting.
Thank you very
Bye-bye.
much. Thank you.
Thank you. Thank you, Aitan.
Yeah, hi again. Good evening, everybody. And really thank you very much for this organization, for having me here. It's my great pleasure and honor. Today, I would like to talk about the management of the airway penetrating trauma. So I would like to give some tips and tricks about the management of these traumatic airway injuries. So it can happen anytime It can happen in the emergency department or in the operating theater or even in the intensive care units. So we have some guidelines, we have some algorithms about them, and we need to be always prepared and have the second plan or the third plan for managing them. Well, there will be some names of trademarks or devices. I have no conflict of interest. I would like to mention this. First of all, I would like to start with the definition. The upper airway traumatic injury is any injury that occurs when an object pierces the skin and penetrates the airway, the upper airway. So according to the reviews and the literature, we can define it. There is a Schaeffer-Fuhrmann's classification. So according to this classification, we can classify the laryngeal injuries into 5 different categories, 5 different grades. So according to these grades, we can determine how big is the injury, so how serious is the situation of the patient. So according to Schaeffer-Fuhrmann's classification, grade 1 is just minor endolaryngeal hematoma. There is no detectable fracture in grade 1. In grade 2, it is most commonly seen. There's edema, hematoma on the upper airway in larynx, minor mucosal disruption without exposed cartilage or non-displaced fractures. Again, there's no fracture. In grade 1 and grade 2, there's no fracture. Grade 3 is a massive endolaryngeal edema, extensive mucosal lacerations, exposed cartilage, displaced fracture now in grade 3, or there are some vocal cord immobilities. So grade 2, as you see, starting with the grade 3, it becomes more serious. In grade 4, it is same as grade 3, but with anterior larynx disruption, and there are some fractures, but these are unstable fractures, and more than 2 fracture lines or severe mucosal injury are added to these laryngeal injuries. So these are really serious. And in grade 5, there's complete laryngotracheal disruption. So according to the classification of Schaeffer-Fuhrmann, so you can determine how to treat them, how to approach them, or you can determine how mortal can it be, the situation. When we look at the incidence, according to the literature, according to different published papers, so there are different data. For example, the incidence of airway injury in patients with penetrating chest trauma, it can range, the incidence is between 1% to 2%. And for the penetrating trauma, for blunt and penetrating traumas, the incidence of the traumatic airway is for the blunt trauma is 0.4%, and for the penetrating, if it is penetrating trauma, it is more than 10 times higher. The incidence is about 4.5%. So according to another study, the traumatic airway injury incidence is less than 1%. And in another study, it was declared that the penetrating neck injury constitutes about 5 to 10% of traumatic injuries in adults. And if there is a laryngeal injury, the mortality rate increases about 10 to 15% among all the patients. So these are really serious numbers. And we know that cervical tracheal trauma occurs about in 8% of penetrating neck injuries, and they can result in major morbidity and mortality. So these patients are critical patients and need emergency care. And we can also classify according to the place where the injury is placed. So according to the field, so we can determine them zone 1, zone 2 and zone 3. Especially the most common area here is placed in zone 2. The 77% of the upper airway injuries are becoming here. Because it is most vulnerable place to be injured during the trauma or accidents. This part is the most frequently injured part, but also the surgical access is also easier here. So if the patient has hemorrhage, if it is grade 3 or grade 4, it is easier to reach there and control the hemorrhage. So this part is mostly injured part, but zone 2 is also the most accessible part of the neck. So these are the classifications. Yeah, when we look at the etiology, the upper airway bleeding so can make the airway management challenging. It may be just spontaneous or idiopathic bleeding, like a simple nasal bleeding. But usually the etiological reason is about the tumors, the malignancies. Sometimes vascular malformation can cause the oral, nasal, or laryngeal bleeding, or sometimes pharyngeal bleeding. Sometimes the patient can be under anticoagulation treatment or can be under thrombolytic therapy or a kind of coagulopathy may be in these patients. So these reasons also may cause pharyngeal bleeding following the thrombolytic therapy. And of course, the trauma is another etiological reason. Trauma to face, trauma to the directly neck can cause some maxillofacial injuries, neck or laryngeal injuries. Sometimes it may be post-surgery, post-operative period. And in a few time, I would like to give you an example, a video of our case in the postoperative period. So as a postoperative bleeding in the upper airway, it may be because of post-tonsillectomies, sometimes post-cancer surgeries, or following some oral cavity or dental implant insertion surgeries, and sometimes after tracheal resection, there may be a massive bleeding. So sometimes they're iatrogenic, often due to the airway management. Sometimes drug abuse, like cocaine abuse, they can cause to nasal or alveolar bleeding. And we have so many challenges posed by the upper airway bleeding. So the first challenges, they are really difficult. So they cause to difficult airway management. So managing all these scenarios are really difficult, and you may fail. I will tell you about the techniques that can be used during these scenarios. But we have to keep in mind that any technique that we use may fail. So we should be prepared for the second, for the third, maybe for the fourth plan to manage the airway. So we should keep already ready for the altered functionality, maybe keep ready the devices for the airway management. And pre-oxygenation or denitrogenation are less efficient for these patients. And supraglottic airway devices are not suitable devices because they are not definitive airways. So for these patients, we need definitive airways. So we need to intubate the trachea. So we need to place the tube inside the trachea. Of course, we can use, as you know, according to the difficult airway management, when you fail in tracheal intubation, the first choice is supraglottic airway devices. So for the ventilation, for the oxygenation, you can use the supraglottic airway devices. Or I would like to also give you an example on my other slides. So you can also place a supraglottic airway device in order to intubate the trachea. So it is another option. So the other challenges, high flow nasal oxygenation. So as you know, we use in many fields in the ICU or in the operating theater, especially for the difficult airway management, we use the high flow nasal canal oxygenation. But the challenges here, so this may also fail. So you cannot sometimes denitrogenate, or you cannot use the high flow nasal oxygenation systems, the transnasal humidified insufflation systems appropriately in these patients. Sometimes they require urgent or emergent hemostasis. And the concomitant suctioning is important, because our enemy here is blood, especially because the blood clot can sometimes mimic the tissue or the pathology. Sometimes the blood clot can obstruct or displace the airway, and it can cause a cannot intubate, cannot oxygenate situation. And so these patients often have a limited functional residual capacity, and they can often lie flat. So this is another challenging problem. And sometimes you come across with these patients after hypovolemia. So after bleeding, they're coming to the hospital. So hypovolemia can be another challenging problem for you. And because of the aspiration risk, due to the blood in the upper airway or inside the stomach, so there's always an aspiration risk. So we should keep in mind that there may be also an aspiration risk. And we have to also be careful that the patient may require emergency fauna, front of neck access. So we can be prepared, we should be prepared for the surgical airway techniques, the front of neck access systems. And our clinical team should be aware of this morbidity, of the mortality rate of these patients, and they should be aware that there's a big stress during the management of these patients. So after this introduction, let's look at the techniques. There are several techniques in order to manage these patients. First of all, you can use flexible video endoscopes, guided intubation through the supraglottic airway devices. So you can place a supraglottic airway device, and inside through the supraglottic airway device, you can use the flexible endoscopes, and you can intubate your patient. Especially there are entry tubes, entry tracheal tubes, entry catheters. As you know, according to the DAS guidelines, which was published in 2011, entry intubating catheters are preferred catheters, are recommended catheters in order to intubate the trachea through the supraglottic airway devices. So you can use these catheters by the supraglottic airway devices. The second option may be retrograde intubation. So I would like to talk more about retrograde intubation. It is, as you know, maybe most of us just saw them, just saw their name in the book, in the oldest books. So we had never chance to perform a retrograde intubation. It's a rare situation, but especially during the airway workshops, we try to teach this technique to the participants, the retrograde intubation, because especially for the blood airway, I'd like to also show you another video about retrograde intubation. Especially for the blood airway, it really works very well. So you can secure the airway by using the retrograde intubation. Blind oral or nasal intubation techniques are written in the books, but today in this world, so the year is 2022, we have so many options of fiber optic techniques for camera systems. So the blind techniques are not recommended anymore. But they are still among the techniques for securing the airway in the books. The light guided intubation is another technique you can use. So as you know, we use very frequently the ultrasound guided techniques. So ultrasound guided regional techniques and ultrasound guided intubation. So before the procedure, it is strongly recommended to identify the cricothyroid membrane by using the ultrasound and make a cross there. So in order to be prepared for the surgical airway management. Cricothyroidotomy, crico is another technique you can use. It's not mandatory. You can even start with the crico. So you can even start as a first choice with the cricothyroidotomy as a first choice. The surgical technique may be the first choice if the patient is not stable. If according to the 4 months classification, maybe grade 5 or grade 4, you can just start with the surgical airway management techniques under local anesthetics. So you can also keep in mind, or you can start with other techniques like awake tracheal intubation or maybe under general anesthesia, rapid sequence induction. It is also recommended if you use the under general anesthesia, but you have to be aware. You have to aware that you have to keep in your mind that this patient can go on to surgical techniques. So the patient may need crico in any time. So you have to be careful and you have to be prepared. Also, surgical tracheostomy is another option. So you can keep in touch closely with the ENT surgeons, and you can just perform the tracheotomy as a first choice or as an alternative technique. Another technique is a cardiopulmonary bypass, or you can consider the ECMO if there's a total injury like grade 5 Fuhrman's classification. So you can also consider for the patient undergoing ECMO. Yes, we have some key points for the airway management. I would like to briefly summarize them also. First of all, I would like to mention that there's a lack of evidence. So these are rare situations for the airway management. And there is no best practice for the airway management in patients with a traumatized airway. So the practitioners, in which technique they feel themselves most competent, they should use it. So if they're not capable of, if they're not feeling themselves competent in fiber optic techniques, they can shift to the video laryngoscopic techniques. If they cannot feel themselves very confident in video techniques, so they can use the supraglottic airway devices, and intubation through the supraglottic airway device, it may be an option. So there's not a best option, there's not a best technique. But we should choose the best one according to the patient safety, of course. And we should at least learn one of the techniques in order to perform one of the awake techniques, maybe. So another thing is there's a presence, usually there's a presence of blood, sometimes vomitus, secretions, or tissue edema. So they should alert the anesthesiologist to consider the alternative approaches. So you should be prepared for the alternative techniques. And also you cannot forget that in some way you have to be control the airway in a surgical airway, by using a surgical technique. So it should be in our mind. So as I mentioned to you before, there's a big failure rate for these patients. So you have to be ready for every situation, and you have to create your team, inform your team, and also you have to choose the best option and inform your team. And teamwork is also very, very important here. So but you may have, I want to also say a few words about the teamwork. So you may have a team consists of experts, but if they don't behave like an expert, So it means that you are in trouble. So for example, in your team, you have a very experienced ENT, but if your ENT surgeon is not helping you during the procedure or is under stress, so it may be a big problem. So team management, also teamwork, and also the non-technical skills also during these procedures are really so important. Yeah, let's go on with the challenges. So yes, proglottic airway devices are recommended techniques for the failed ventilation or oxygenation. So you can use temporary for these devices in order to ventilate or oxygenate your patients, or you can use these devices in order to intubate your patient through these proglottic airway devices. As I mentioned, retrograde intubation is another approach. Light guided intubation, cryo, tracheostomy, ultrasound, guided intubation, oral digital intubation, or cardiopulmonary bypass are another techniques. But as you see here, if any of the techniques, whichever you use, the awake techniques are recommended. So awake proglottic airway devices or awake retrograde intubation, in the first line, if you can perform, please use the awake technique. So this is the most recommended technique in order to survive these patients. Yeah, so let's go on with the key points for the airway management. 2 direct laryngoscopes are recommended. Please, one of them should be video laryngoscope with the MAC blade. Why MAC blade? Because MAC blade, we are very used to use it. So in our daily practice, we usually use a MAC blade. And if you have the video laryngoscope with MAC blade, we call them standard blades. So it's better to use the video laryngoscopes. And so it may be the light may gone, or the view may be blocked by the blood or by the secretion. So in order to suspend these cases, in order to go on, in order to manage these patients, so 2 direct laryngoscopes, at least one of them should be video laryngoscope, are recommended. 2 rigid large bore Yankover type suction catheters are recommended. And this is also another important thing, because one of your Yankover type suction catheter may be blocked again with the blood or the secretions. So an assistant should be dedicated to the suctioning. So you should use one of your team member. Just duty should be for the suctioning. So one should be dealing with the tracheal intubation, maybe 2 person, 1 surgeon, 1 anesthesiologist is better, and one colleague should be dedicated for the suctioning. Magill forceps, we usually use it, especially for the retrograde intubation, so it should be ready during these procedures. A malleable intubation guide, bougie, introducer, all of your emergent settings, so all of your airway management devices should be already there. Following intubation, suction down the tracheal tube is also important, and checking the airway by using antidic carbon dioxide are strongly recommended. So at the end, we should use an endotracheal tube. This endotracheal tube can be used in the oral route, can be used in the nasal route if you're lucky, because especially the trauma patients can come to the emergency department or to the OR with the midline injuries. So sometimes you cannot use the nasal route if there's a bleeding inside. So sometimes you have to it's mandatory to use just the oral route. Or you can use the tracheal stoma, or you can sometimes insert the cuff tracheal tube inside the carotid membrane. So a cuff tracheal endotracheal tube should be used in 4 of them. So this is an algorithm. Michael Christensen, a very close friend of mine. So we are working together in the European Airway Management Society. He's a past president of this society. They published this nice paper in 2020 in Canadian Journal of Anaesthesia, and they created an algorithm for the upper airway bleeding. So first of all, the first recommended thing is compress the bleeding site if it is accessible, but mostly it is not accessible. It is inside the oropharyngeal cavity or inside the trachea sometimes, inside the larynx sometimes, so coming from the upper airway. So if it is possible, yes, compress the bleeding, but it is mostly, it will be not available. So the patient positioning is important. The upright posture, so in the sitting position or in the semi-sitting position is important. Not lying in the lithotomy position. So it should be in the upper, the head up position. So in the semi-sitting position or sitting position, it is better for the patients in order to ventilate, in order to keep their upper airway safe, avoid the aspiration risk. So suctioning and oxygen all the time. Oxygen, if possible, you can use the high flow systems, but it may fail. You should keep in mind, but you should continuously give them oxygen. Suctioning is very important. As I mentioned, one person should be dedicated for just suctioning. So fluid resuscitation and cross-matching is another step for the management of these patients, for the preparation, because mostly these patients lose a lot of blood, lose a lot of fluid. So they may be dehydrated, or they may be anemic during their arrival inside there. And afterwards, you have to be prepared for also the bleeding. So you have to cross-match the bloods, be aware. So let them know about the situation, the blood bank. So you have to alert them, and you have to prepare the bloods, the FFP, the red blood cells, the thrombocytes, everything, like a trauma patient. And you have to evaluate the airway, including identifying the cricothyroid membrane. So the most important, one of the most important steps is here, the identifying the cricothyroid membrane. So you have to you can palpate it, or what is recommended, you can use an ultrasound in order to palpate, or in order to determine the cricothyroid membrane and make a cross there. So it is your safety margin. So you have to know where the cricothyroid membrane, because if the things are getting worse, so you can just insert your endotracheal tube. You can just cut the cricothyroid membrane and insert your crico or your endotracheal tube inside the cricothyroid membrane. And according to their algorithm, if there's a predicted unsuccessful laryngeal direct laryngoscopy or crico, so awake techniques, awake phono or awake intubation, awake tracheal intubation are recommended. If predicted successful direct laryngoscopy and the cricothyroid membrane are identified, this means that if you are feeling yourself comfortable that you can intubate this patient under general anesthesia, they recommend to go on under general anesthesia with rapid sequence induction and intubation. So yes, it is written in this review, but this part I personally cannot recommend. I just recommend the awake techniques because if there's a fail in the rapid sequence induction, so they recommend rapid sequence induction because they're mostly full stomach, because of bleeding, because of blood, because of secretions. But if there's a failure, so you can consider you can consider very limited. You have this means that you have very limited options. One of them is crico, the other one is tracheostomy. So just the surgical techniques if there's a failure. But if there's a failure in the awake technique, you can shift to another awake technique. You can shift also the rapid sequence induction. So you have or the surgical techniques, you can shift them. So I cannot personally recommend here the rapid sequence technique. So this is important, but this is the algorithm which is recommended by the Michael Christensen et al. Ultrasound guided retrograde emergency intubation can be used for these patients because there is a bleeding inside the pharynx or inside the neck. There may be a laryngeal obstruction, so the neck anatomy may not be palpable. So the fiber optic techniques, the fiber optic intubation can be failed also. Sometimes, these are the risks. So the ultrasound guided tracheal puncture is recommended for the retrograde wire insertion and the retrograde intubation. The retrograde intubation is an old technique, as I mentioned, but it has some pros, it has some advantages. So first of all, it is a simple. It is cheap equipment. It requires cheap equipment and single-use equipment. It can be applied either awake or under general anesthesia, and you can also apply it for the blood airway. So that's why we are trying to teach the retrograde intubation in the airway courses for the participants. It works for the oral or the nasal intubation, so you can use both the routes, and it allows easy reintubation if necessary. So if you need to reintubate the patient, you can also put a catheter, and by using this catheter or guide, so you can reintubate your patient. So that's why retrograde intubation is a recommended technique. Maybe most of us don't use it anymore, didn't have any experience, but in blood airway, we should consider it in our mind. I will show you an example. So again, from Denmark, this video, my friend Michael Christensen, they published it. So this is a patient with a tumor in the oropharyngeal back part. So the tumor is really a big one. It's obstructing the airway, and it started bleeding. So the patient arrived. This is the emergency department. So the patient arrived to the ER, ED, with bleeding, with upper airway bleeding. And they decided to perform a retrograde intubation by using the epidural catheter. First of all, they checked the cricothyroid membrane by using the ultrasound. You can reach the full video in airwaymanagement.dk. I put it from this website. It's a Denmark video. So after the palpation and the ultrasound check, they placed an IV catheter there. So inside this IV catheter, they placed the epidural catheter inside there. And these are the hands of the ENT surgeon, and these are the hands of our colleagues anesthesiologists. So it's a real teamwork. This lady from ENT is trying to catch, is getting back the tongue, and is trying to catch the epidural catheter. Once she catches the epidural catheter, she is getting outside the mouth and place it inside the tracheal tube. I'll show you. So here, the patient is awake, by the way, spontaneously ventilating. They keep the airway spontaneously. So here they place, and inside the mouth, she's looking at, she's searching the epidural catheter, and now she catches it. Here is the epidural catheter. Yes, from the cricothyroid membrane, they get out the epidural catheter. And they make an half a knot by using the Murphy eye, here, and place the epidural catheter inside the tracheal tube. So this is a very nice working technique. So when you place your epidural catheter inside the endotracheal tube, so you can easily shift the endotracheal tube inside the trachea. So here comes the cuff tracheal tube by using the oral route. And what you use afterwards, the epidural catheter? Epidural catheter stays there. So you just secure the airway. And after the surgery, you can go on with the tracheostomy, or you can go on with the tracheal tube, or if it is safe, you can extubate your patient. So this is one of the techniques. The other technique, this was my patient in our hospital in Istanbul, Turkey. So here is an ICU. This patient is a poor lady. Unfortunately, this patient is in the postoperative period. This patient had a surgery in the thyroid. So this patient had thyroidectomy. But during thyroidectomy, this poor patient had 3 different complications. One of them was a tracheal resection. So they accidentally, iatrogenically, they injured the trachea during the surgery. One complication was that. The second complication was the patient was hypocalcemic in the postoperative period because they resected the parathyroids. So the other one, complication was the laryngeal injury because there was a nerve injury, nervous laryngeal recurrence injury, but we were not aware about it. We were just aware about the tracheal injury because there were some subcutaneous emphysema. And we immediately had the patient under urgent life-saving surgery for the tracheal resection. So they fixed the trachea, and afterwards we shifted the patient to the ICU. After tracheal resection, we kept the patient in the ICU 2 days, intubated. And then if the patient meets the extubation criteria, so we extubate the patient. So again, we are in the ICU, we extubated the patient, but we realized that the patient cannot breathe correctly, and there is a kind of hypoxemia. So at that time, the operating theaters were full. They were going on. It was a night time. There were several surgeries in the operating theaters. They were all scheduled, and we have to do something urgently inside the ICU. So before doing something, I called the ENT surgeons. I wanted them to bring their nasendoscopes and to visualize the vocal cords if there is any injury, there's something wrong in the among the vocal cords. And I was right. During the nasendoscopy, we realized that one of the vocal cords was paralyzed. It was not breathing, it was not moving during the breathing. So we realized that during the surgery there was a nervous laryngeal recurrence injury. So that's why the patient could not breathe very well, and the patient started to get hypoxic. The PaO2, the arterial oxygen content, was around 60 millimeters of mercury, around 58. So we decided to reintubate this patient. So our first technique for this patient was awake, placing the awake eye gel, awake supraglottic airway devices. The reason was that I was planning to use the anti-catheter insert the anti-catheter inside the supraglottic airway devices and insert the supraglottic airway and insert endotracheal tube. So our first plan was intubating the trachea through the supraglottic airway device. So we started for the plan A. The patient was prepared for the topical anesthesia. The patient was under sedation by using remifentanil. We used just a single agent, the remifentanil. And we topicalized the upper airway by using the lidocaine, inhalation of lidocaine, and also infiltration of lidocaine, the oropharyngeal area. So the patient was prepared well, so she was tolerating the supraglottic airway device. And at that time, so I decided to place this anti-catheter. This anti-catheter you can preload to the fiber optic scope, pediatric fiber optic scope. And you can, my plan was just getting inside the eye gel. And when I get out of the eye gel, come across with the vocal cords and pass the vocal cords by using the anti-catheter and place the endotracheal tube. That time I cannot show you the image because we couldn't attach it to the monitor. I was just seeing by using this camera. So unfortunately, my supraglottic view, my my camera, my fiber optic view was blocked because I realized that inside the trachea, so inside the surgical area, there was active bleeding. So this bleeding, these blood clots blocked my view. So my first plan was failed. So my first plan was intubation through the supraglottic airway device, and my view was blocked. So I need to shift to the second plan. So I couldn't proceed it. Well, my second plan was a combined technique using the video laryngoscope. Again, keeping the patient awake in spontaneous ventilation. So I performed awake tracheal intubation and plus fiber optic tracheal intubation. So video laryngoscope plus fiber optic scope we used as a combined technique. So the patient was following our comments. So I placed the video laryngoscope here. And this is my colleague. My colleague was thoracic surgeon. And he performed the fiber optic view. So the fiber optic intubation by using this fiber optic scope. By this way, we had two screens. One screen of the video laryngoscope and another screen here, you will see the screen of the video endoscope. So we have two screens, two hands, two experienced hands. So it was much more comfortable and much more safer. So if one of them is blocked by the blood, so we can continue with the other screen. So our second plan was the combined technique. And as you see, I will show you the vocal cords with the video laryngoscope. The patient is still stable, not desaturated, because awake and spontaneously ventilating. As you can see here, I'm sorry. I would like to show you. Yes, as you can see here, yes, you can see the vocal cords here, but there's an active bleeding. So that's why my first plan was failed. I was using a pediatric scope because of anticatheter. You can preload the anticatheter to just a pediatric bronchoscope, not the adult one. And it has a tiny ending, so it is easily blocked with the blood clot. And that's why I shifted to video laryngoscope, and it was there was an active bleeding there. And then I showed it. So my colleague came here with the scope, with the fiber optic scope, and with this one he passed the vocal cords, and then we inserted the endotracheal tube. So at the end, it was successful. So our second plan worked. It was a combined technique with video laryngoscope plus fiber optic intubation, again as an awake technique. So as a summary, upper airway bleeding cases, they are really challenging to manage, and they require a structured, a multidisciplinary approach, especially a teamwork, to achieve a successful outcome. Standard airway management algorithms may be inadequate for this scenario because even the pre-oxygenation is difficult for them. Even the high flow nasal oxygenation systems may fail in these systems. So you should be always prepared for the alternative airway management techniques and also for the surgical airway management techniques. And a multidisciplinary approach, a good coordination, a good communication with the surgeons is essential here. Both the technicals and the non-technical skills using them are crucial for the management of these patients. The hallmark is the maintenance of the spontaneous ventilation and intubation under direct vision, together with the protecting the spontaneous ventilation by using the awake techniques, which is recommended. We should avoid both the intermittent positive pressure ventilation because it may also worsen the vision of your laryngeal structures. Also the cricoid pressure you should also avoid during the if you use a rapid sequence induction, so you should avoid them. The practitioners should thus utilize as I mentioned, there is not a best option. So according to the operator's most competent skill, so they should choose the best one. But there are rare situations, and according to the literature, I cannot tell you there's a best technique. So supraglottic airway device, intubation through the supraglottic airway device is an option. Retrograde intubation is another option. As a first option, you can also use the surgical techniques. A difficult airway due to the presence of blood, vomitus, secretions, or tissue edema are waiting for you, and inability to intubate is an absolute indication for an emergency crico or surgical tracheostomy. So you should always keep in mind the surgical techniques. So this is my last slide. Last week I was in DAS, Difficult Airway Society meeting. I was giving a talk, and I promised them that I will share with the airway enthusiasts this survey. So please take 2 minutes to complete the survey, which is about the airway topicalization in pediatric patients. So, I would like to thank you all for your patience. If you have any questions or any comments, I'm available here. Thank you so much.
Thank you, Prof Kemal, for this informative presentation. Every day you push me to like the difficult airway and to be engaged in it. And Prof Kemal spoke first about his presentation about the incidence of airway trauma and different types and the mortality rate. And he speak about etiology and the challenging like bleeding, aspiration, and many challenging situations. And they speak about the technique and usually go from simple to advanced. And they usually use the technique you master and don't try a new technique during emergency. And he speak about training is a very important issue about to master some technique. And he give us a special point or tick and trips, how to manage the patient, compress the bleeding, upright position, because you treat the patient and you are not treating an airway only. So you stabilize your patient and go for pathway. There is a difficult pathway and a good pathway. And he give us a piece to case-based discussion and listen from this discussion that it is not one-man show, it is a teamwork and usually success with teamwork. And also he given a very good end point about how to deal with the patient and what is the challenging and what to do and what to not to do. On the floor now for question. Anyone have a question can go for chat box and can put his question. But before that, I have one comment and one question for Prof Kemal. The first comment is that during my case, the previous case I told about you, I don't discover that the tube outside by far optic, but because it was a bleeding and soft tissue injury. But I discovered easily by ultrasound, because when I look up, I don't find the tube. When I come down, I found the tube. So I discovered this is anterior. Even the thoracic surgeon, he don't discover it by ultrasound, by fiber optic, because it's a horrible bleeding, as you said. Every tool have its function. But my question in the future about artificial intelligence, because now artificial intelligence working in all machine would use, like anesthesia station machine or ultrasound machine. Do you think that artificial intelligence will have a role in this difficult scenario? And we know that there is some studies about that. What's your opinion about that?
Well, artificial intelligence, yes, there are so many studies. So it is integrated to the airway management in different parts, especially for the preoperative assessment. So according to the studies, we have some facial recognition systems. So they can, according to the pictures, so you the face recognition systems, the face picture, so you can give you a prediction about the airway management. But for the bleeding of airway management, I couldn't think now. For the bleeding, I didn't come across, but I don't know how can it be. Yeah.
It's okay. I have a comment here from our colleague, Dr. Samir Kafraoui, is a big fan for the MAPIC. And he said that usually he make a retrograde and use a guide wire. So I need your comment, but I have a comment because I was working in National Cancer Institute. And when we use a guide wire, we make more trauma because, you know, guide wire like a metals, when we're tracking, you make a more trauma. And because of that, we give a special tool specialized for retrograde. It is like a guide wire over it, a plastic or a rubber tube over it, like dilator for tracheostomy, and it would be more malleable, less injurious. But what's your opinion about that? Use and guide wire for central line for instead of your catheter or for epidural catheter.
Well, it is these are patients. These patients are really very vulnerable patients. So there are so many tumors there. There are so many bleeding areas. So the tissue can be easily damaged, as you mentioned. So I'm trying to avoid to use the catheters, you know, the rigid catheters. I have experience with the epidural catheter, not with other parts, but there are some special kits, some special sets dedicated for the epidural for retrograde intubation. There are soft tissue, so soft tips, so you can prefer them. But I have experience with the epidural catheter, so it works well. Of course, it may make a kink, so you have to be careful about it. And it's a teamwork, as I said. One should catch inside the oropharyngeal area, so as soon as possible. You can also use the some devices to catch it. So, but they are really vulnerable, so they can easily bleed and make it more complicated, your work. So,
yeah. I think it's the opinion also of our colleague here on chat box, Dr. Sadiq, my friend, and some people just subjected to use this catheter, and it work in many situations. And I just accustomed to use it when I was in Cancer Institute, but for about 20 or 25 years, I don't do it. But it have a role, and as you said, what you must study, you do first. Different from place to place, and the guideline just like a spotlight on the road. But if you have anything for first thing for the guideline and you can do it, don't do it. Guideline is just a spotlight on the road. Any more question about the presentation? Because it's supposed to be a wealthy discussion, and any area of debate is an area of discussion,
I think there's a comment that CVP catheter is not sharp, so they have some experience by using this catheter. I didn't use CVP catheter actually.
We use it, Prof Kemal. I use it many times, and they make more injury than help for us, because usually we make it tight, make it stiff, and stiff usually cut the trachea, cut the mouth, cut anything.
Yeah.
So, and after that, we get there is a special tool. This in the market, special catheter, like a tracheostomy catheter. It's a guide wire, and over the guide wire, make a dilator, and make what's called dilator, small plastic or rubber, which you not cut, and make it malleable and more easy. We use this tool previous time, but I don't know, we don't have, or I don't ask it about it here in our hospital, because usually I'm not engaged in this difficult case. Yeah.
At the end, so you place blindly. So yes, you pass the cricothyroid membrane. Of course, you see it, but afterwards, when you reach the oropharyngeal area, so it's blind. So if the tip is not soft, so you can make an injury. Yeah, I agree with you.
Yeah, you know that I have here a comment of one of our colleagues, and they're asking if you face a case was not suspected. You see, this is a very difficult case for difficult surgical airway, or even difficult intubation, like severe injury for upper airway or the face. What's your situation? What is your suggestion about that?
Mm-hmm.
What's your suggestion if you face this case? Yeah.
For unconscious patients, uncooperative patients, you mean?
Yes. Yes, sometimes it's very difficult injury, or just another question joined to that. If you find a patient, as your patient very cooperative and conscious, but if you find an unconscious patient not cooperative, what's your situation? Difficult, very difficult airway, and the patient like this, and desaturated very fast. What's your suggestion? What is the first thing you do, and second thing you do, and what's the third plan even?
Mm-hmm. Yeah, so first of all, I would like to mention that according to the, how can I say, if it is really difficult, if the patient is in the end stage of tumor, they're mostly aware that it's a difficult situation, so they try to help you. So in order to during the situation, and you can easily keep them awake. But of course, we have some agitated, some panic patients. We have also some unconscious patients. So in order to deal them, you can always start with the surgical management. So you can be in touch with the ENT surgeons and with the locals. So you can put the first crico, and then you can proceed the surgery, or you can even try the trachea intubation. So you can start with the surgical techniques by using these patients. If the patient, if you are not expecting a difficult airway, they recommend the rapid sequence induction, but as I mentioned, I cannot go with rapid sequence induction. So I find it very unsafe. So everything can happen during this procedure. So especially the oxygenation is important. So if you sometimes, if it is possible, I just prefer to use the high flow nasocanal oxygen systems. But sometimes if there's an active bleeding, it can also spread the blood to everywhere. So it can also block your view. So otherwise you can use the low flow oxygen system. So every time just don't let the patient to breathe in the room air. So every time I put the nasal cannula there or the oral cavity, so an insufflation should be in place every time 100% oxygen, of course.
You answered
And
the third question.
Sorry, during
Yeah,
this
Prof.
procedure, I also use just sole agent, so just one agent. Especially I use remifentanil. According to the studies, dexmedetomidine is strongly recommended just for using dexmedetomidine. But sometimes if you mix the drugs, for example, together with midazolam propofol or remifentanil plus midazolam, so the patient can be unconscious, so you can lose the patient. It may be quickly agitated. So I think the best way is using just a sole agent, a single agent. I find them more stable when you use just one agent.
I think one of our colleagues asking again, you answer the question of Prof. Wissam, but also Prof. Wissam asking, is there any role for rigid bronchoscope in difficult airway management or not?
Yeah, we sometimes use rigid bronchoscopes, and the ENT surgeon, thoracic surgeon, they have big experience by using these rigid bronchoscopes. So we can help their help. So they have also apparat for the, the ventilation apparat. So by combining the jet ventilation also, we can use the sometimes these apparatus, so they can easily lift the epiglottis by using these rigid endoscopes. Sometimes they pass the vocal cords, or they can sometimes guide. Sometimes we combine this flexible bronchoscope and the rigid bronchoscope together. So we use this. Yeah. Even for the
I have an event happened to me, but I need your opinion about it. They call me one day from home that we have a patient with tracheal stenosis and have a difficult, the situation is 60, and you're pushing the patient now, and you must come as possible as you can. I came from Goma Prayer by my shop or Galabia to see in Egypt. I ran to the hospital, and I went there. I found the surgeon want to make a tracheostomy, and he make a tracheostomy before, just to go for the same place, and he tell me that I make a block neck dissection, so nothing in the neck, all the stuff. But I found the neck is not a regular neck. So I tell him just, I can put a needle for you in the trachea in 4 seconds by ultrasound. Give me the chance. He tell me that everything is appear here. I can touch everything without ultrasound. So he tried to put the tube. First thing, he make an opening on the tracheostomy, and they put a tube, and the patient is struggling because situation 60 and coughing, and it is a tumor, necrotic tissue came from the tube. And as the patient arrested, we put a small tube, 5, for the trachea. We try to resuscitate, and we succeed to resuscitate, but the saturation is 50, 60. And, after 26 minutes, he succeeded to put the tube inside the trachea. And after that, we found that not only the problem of tracheal stenosis, that the tracheal collapse. And we try to make a suction for the bus make like a cast. And after 1 hour suctioning the bus from the trachea, the patient gets saturated 100%. I tell you, this saturation was 60 on 100% air. So I asked him after that, he's a very good surgeon. I tell him, we must put a guideline for these cases, because you make me 26 minutes to struggle and the patient can die because you refuse from me 4 seconds. Do you think we need guidelines for such a situation? Because it happened, this is the second time to happen in 2 years with me.
Yeah.
And do you think we need guidelines, or just what's called guideline, or just any advisory just to how to proceed with this case?
Yeah,
or what's
of course.
your comment about this case?
Yeah, we need some recommendations, some algorithms, even the guidelines. So these are the really gray parts of this recommendations, the guidelines. And I would like to also add you, I have some experience in the emergency department when it is an urgent situation. So when it is an urgent situation, the ENT surgeons are really very bad. I don't know if they are listening us or not, but in urgent
You
situations,
see him in ECC, I think. You see some of in ECC.
yeah, but the ENT surgeons are quite bad in urgent tracheostomy. Urgent, they really consume time, at least 10 minutes sometimes. I come across, so the patient was when they called me, they were starting the resuscitation, and the ENT surgeon was there. They tried to perform an tracheostomy, but it was very late. So in these situations, the best way is, according to DAS guideline, which was published in 2020, just cut the cricothyroid membrane by using the, cut it and place the number 6 in the tracheal tube. So this is the best way. Cut the cricothyroid, place the guide, and by using this guide or place the number 6 in the tracheal tube. Afterwards, they can do what they want. But in urgent situations, also ENT are sometimes mostly useful, unfortunately.
Yeah, thank you, Prof. Kemal. There is another question from our colleague, Dr. Mahmoud, because I think he sees this facing this case, he asking if I face a case with severe tracheal injury and intervention by otolaryngoscopy ENT surgeon and has failed. Could thoracic surgeon save us in this crisis? He's asking about teamwork.
Yeah, thoracic surgeons, so they have maybe cardiothoracic, we can say, because if you have the cardiothoracic surgeon, they can immediately shift to ECMO, take the patient, or the cardiopulmonary bypass machine, they can place it. So it may be another option if the patient is young, or pregnant, or so you can give another choice if there's no option.
Another question from, sorry, Prof. Kamal, we can pressure on you. I know that you finish your work at 7 o'clock, and I know it's a hectic day for Hamad if you got it then weekend. I know that it's very bad days, But I have here an asking question from, just to try to get as we can from you as a good source, How could we expect a case of tracheomalacia? And how can you expect it and diagnose and post-operative management of these cases? In some cases, we face this situation.
Yeah, tracheomalacia is a really rare situation. Can you determine by using the ultrasound? I would like to ask you.
Also, how you diagnose post-operatively? We expected, can you put a tube for some time, the patient come intubated, or just you need a surgical airway, or what we can deal with this case?
Same scenario as post-thyroid.
Yeah, as post-thyroid, for example, scenario as Some case you expect to be a tracheomalacia and Israeli tracheomalacia, but the problem in this question that the tracheomalacia different from nothing to a collapsed lung or obstructed upper airway. So what you deal with a suspected case, you need just for ICU, for example, or to put a tube for some days, or what you can deal with these cases.
Yeah, in these cases, I use the tube exchange catheters. So the extubation. So the extubation is all the situations must be so stable. So the patient should be stable, all the vital parameters, everything. And we perform a cuff leak test. So we inflate the cuff and get if there's a leak. So otherwise we use the steroids in order to release the edema. And we usually place an exchange catheter or extubation catheter. There are some several catheters, single catheters, or some extubation sets. So we use them. The important thing is here they have some holes, so you can give oxygen insufflation during the procedure by using these extubation catheters. But please do not ventilate this patient. Do not try to ventilate these patients. We had one patient, so it was a difficult intubation. So we performed an awakened trachea intubation. It was easy. Again, it was an oropharyngeal edema. The mouth opening was almost, there was no mouth opening. So the nasal awake trachea intubation was successful. And afterwards, I placed an tube exchange catheter. But after I get back the tube, there was a mild hypoxemia, a mild desaturation on the patient. I was together with my resident, and my resident started to try to ventilate with the back valve mask. So unfortunately, there was a pneumothorax. So you have to be careful because these are very thin structures. So these devices are very useful to reintubate the patient, but not for ventilation, just for oxygen insufflation. So be careful.
Thank you, Prof. Kemal. I think it's the end of the session, and you know that for me, I'm just thank you very much. I get a lot from Lou, and this is the station now for Prof. Safa to give a beautiful word about the comment about Prof. Kemal.
Thank you very much. It was my great pleasure to be with you. Thank you, Dr. Safa. Thank you, Dr. Yasser. So thank you for the participants coming here and for their comments. Yeah.
Really, I have no suitable words or letter to appreciate you, Dr. Kemal. It was my great honor and the pleasure to have you this night. Many, many thanks for your distinguished presentation. It's really a reference in penetrating airway trauma. And your optimistic contribution for our e-learning program. Thank you. Thank you for paying your effort and time fruitfully and kindly. Thank you for your kind support. Thank you, Prof. Yasser, for your time and effort. This night is distinguished, sweet night because of your presence. You are so elegant presenter, Dr. Kemal. And please, if you allow me to have another time in the coming year, inshallah, in 2023, I will be continuously remind you that we want a presentation from you again, Dr. Kemal. And please expand my greeting to Professor Dr. Aitin. She is so elegant and fruitful, kind wife. My greeting for her. Thanks for her contribution. And we have got you from her. So I am so sorry to have you this night from her. دكتور ياسر شكرا جزيلا لحضرتك.
I have one word to see for Kemal. يكن تكرار groceries.
Thank you very much for the
glugli.
Thank you very much.
We need to see you more time and goodbye. Glugli. But goodbye, but it's a straight word in Turkey.
Yeah.
Goodbye. Salam.
دكتور ياسر ان شاء الله الاسبوع الجاي معنا دكتور عبد العظيم الدولاتلي ان شاء الله يوم 28 باذن الله اكتوبر. وطبعا بروفيسور عبد العظيم is one of our eminent great professor and it is so glad to meet him ان شاء الله الاسبوع الجاي. وبس احنا هنبث الاذاعه بتاعتنا من المنيا الشقيقه.
Inshallah, next time before the non-Arabic speaker, the Prof Dawlatli will be with us in our platform, and it will be just our broadcast will come from Minya because there is a conference. Dr. Safa will make a dual work that the speaker in the Minya, and at night it will be the head of broadcast from Dr. Dawlatli. And I invite you to come because this is one of our professors who make a very valuable anesthesia, especially about thoracic surgery. And I hope, inshallah, to tell your colleague, because then it will be a very good educational session.
إن شاء
Thank
الله.
you. Thank you,
دكتور
Kemal.
كمال. Thank you دكتور كمال. Thank you Prof Kemal.
Thank you very much. Thank you. My
Thank you.
pleasure.
Happy to see you. It's my great
Inshallah.
pleasure
Salam
دكتور
alaikum.
كمال.
Thank you
عليكم
for your
السلام.
time. Salam alaikum.
Thank you. Thank you.
Thank you.
شكرا دكتور ياسر. شكرا لحضرتك. شكرا.
Salam alaikum.
Thank you دكتور كمال. Thank you.